I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. People with diabetes are at higher risk from COVID-19. Did you know that this infection itself can lead to diabetes? This is the People's Pharmacy with Terry and Joe Graydon.
At last count, over 44 million Americans have been infected with the coronavirus, and over 700,000 have died. Those who survive, however, sometimes face long-term consequences. It turns out that this virus can put people at higher risk for the complications of diabetes.
When's the last time you had your blood sugar measured? A lot of us have put on a few pounds during the pandemic. Has that driven blood glucose higher than it should be?
Coming up on the People's Pharmacy, learn about the vicious cycle of COVID and diabetes.
In the People's Pharmacy health headlines, myocarditis is a recognized complication of COVID vaccination. This adverse reaction has discouraged some people from getting a shot. How often does this inflammation of the heart muscle occur? Research conducted in Israel found 54 cases of myocarditis among 2.5 million vaccinated adults. That's an incidence of 2.13 per 100,000 people. The incidence was higher in young men between the ages of 16 and 29. According to the Israeli researchers, most cases of myocarditis were mild or moderate in severity.
Disturbing new evidence shows that people with diabetes who take statins have more difficulty controlling their blood sugar. The researchers utilized medical records for more than 160,000 VA patients. Half of these individuals started on a statin between October 2002 and September 2015. Analysis of the records showed that statin users were more likely to have progression of their diabetes. In addition, those on higher doses of statins for more intensive cholesterol lowering had the greatest odds of their diabetes getting worse. Many doctors maintain that getting cholesterol under control is critical for people with diabetes, since they're especially vulnerable to heart disease. Physicians should monitor patients with diabetes especially closely if they're taking statins. If blood sugar starts to rise, medication doses may need to be adjusted.
Americans are being urged to roll up their sleeves for this year's flu shot. The CDC suggests that people call ahead to make sure there's a vaccine available. The reasons to be vaccinated against flu are to help you fight off the infection yourself and to help protect others from influenza. Last year, the U.S. had a very low level of flu, possibly because of the precautions people were taking against COVID-19 transmission. Likewise, Australia has had an extremely light flu season during their winter, which has just ended. As a result, vaccine manufacturers have had to guess what influenza virus might be prevalent this year. If people maintain precautions against transmission, we might have another light flu season this year.
The CDC has been doing a lot of flip-flopping lately. When the pandemic began, the agency insisted that ordinary people did not need face masks. Then they reversed that decision and stated that cloth or fabric face coverings were the answer to the spread of the coronavirus. 6 feet of distance was recommended to prevent droplets from carrying the virus between individuals. Now there's general recognition that viral particles can travel much farther than 6 feet. Good ventilation is essential. The latest flip-flop has to do with upcoming holiday travel. Initially, the agency told people to avoid in-person gatherings around Thanksgiving and Christmas. Instead, families were urged to plan virtual celebrations. That was last Friday. A lot of people were disappointed in that guidance now that more than half the country is vaccinated. 3 days later, however, that advice had disappeared off the website. We're still awaiting revised recommendations. For people trying to make travel plans for the holidays, this lack of clarity is a challenge.
As we age, our stomachs often produce less acid. This could result in poor absorption of vitamin B12. Irish investigators analyzed data from almost 3,300 older people in the Trinity Ulster cohort. They found that 15% of these senior citizens did have atrophic gastritis due to inadequate acid production. Of these, 38% had vitamin B12 deficiency. By comparison, 21% of volunteers taking acid-suppressing drugs and 15% of those with neither risk factor were deficient in vitamin B12. Those who regularly consumed fortified foods were less likely to be deficient in vitamin B12. However, even the crystalline form of vitamin B12 used in fortification was not quite enough to overcome deficiency due to atrophic gastritis. The investigators wrote, "In conclusion, older adults who have AG and/or higher dose PPI use are more likely to have indicators of vitamin B12 deficiency." And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. COVID-19 has caused no end of misery. According to the Johns Hopkins Coronavirus Resource Center, the virus has infected more than 236 million people worldwide. Nearly 5 million have died. But that's not the end of the story.
We've learned that long COVID affects anywhere from 10 to 30% of the survivors. There are dozens of symptoms, including shortness of breath, overwhelming fatigue, heart palpitations, tinnitus, changes to taste and smell, and brain fog. In addition, there's a mysterious condition called POTS, P-O-T-S. It stands for Postural Orthostatic Tachycardia Syndrome. In this condition, the autonomic nervous system can't regulate blood vessel responsiveness properly. People get dizzy when they stand up, experience a rapid heart rate, and may have their blood pressure drop dramatically.
Another serious complication is diabetes. The virus could be directly harming beta cells that make insulin. It might also be triggering an immune response that damages the pancreas.
To learn more about this complication, we turn to Dr. Mitchell Lazar. He is the Willard and Rhoda Ware Professor in Diabetes and Metabolic Diseases and is the director of the Institute for Diabetes, Obesity, and Metabolism at the University of Pennsylvania.
Welcome to the People's Pharmacy, Dr. Mitchell Lazar.
Hi, Joe and Terry. Thanks for having me, and I'm really looking forward to speaking with you.
Dr. Lazar, you treat patients with diabetes, type 1 as well as type 2. Early in the pandemic, we heard that people with pre-existing conditions, including diabetes, were more susceptible to COVID-19. Could you tell us a little more about that, please?
Sure. Well, like most aspects of COVID, this all happened so rapidly, and there's a lot to unpack, a lot we don't know, but it's absolutely been the case that people with diabetes, especially type 2 diabetes, appear to be more prone and also more severely affected by COVID infections. At the same time, COVID infections may actually predispose or increase the frequency of new diabetes, which is more like a type 1 diabetes, in certain patients. And we know a little bit about this, but there's still a lot to learn.
Are people with diabetes more likely to die if they get COVID?
They are, but I think that with improving therapies and knowledge about what's going on, this is less of an issue, but it has been statistically the case. It seems that we know that type 2 diabetes is a situation where people have sort of a chronic inflammatory condition, which includes producing in their bodies already some of the cytokines that go off the charts in people when they're affected with COVID. COVID is an acute infection, as we say. Diabetes is more chronic. But it seems that this may set the patient with, or the person with type 2 diabetes up for a more severe case.
What are cytokines?
Cytokines are molecules that are kind of like hormones because they circulate in the bloodstream, but they're not made by classic endocrine glands. They're made by inflammatory cells, and they tend to ramp up the immune system, and they're actually very helpful when we sprain our ankle or other conditions where our body is trying to treat a condition by creating inflammation. But when they go out of control, as occurs with certain bacterial infections, but also with COVID-19, they have an effect of just having too much inflammation, causing all sorts of problems, especially in the lungs and other tissues. So that's why it's sometimes called cytokine storm that occurs in COVID. The low levels of cytokines in type 2 diabetics don't normally cause this, but they might sort of prime the pump for what happens with COVID.
Dr. Lazar, you said something startling. I mean, it really caught my attention, and that is the idea that someone who has COVID-19 might be more susceptible to developing type 1 diabetes after they presumably recover from the viral infection. Could you explore that in a little more detail? Because I think there's been a lot of interest over the decades. Is there some viral infection that causes type 1 diabetes where the immune system begins to attack those islet cells in the pancreas? And so are you suggesting that maybe this coronavirus is following in that path?
Joe, that's a great question. And I would say that's a speculation that there's starting to be some evidence for. You're right that type 1 diabetes, which is an autoimmune condition where the person's own body attacks the parts of the pancreas called the islets that make insulin. And that has been suggested to be triggered by viral infections that trigger the immune system. Maybe they cause the cells that make insulin, which are called beta cells, to be more inflammatory and more susceptible. And it turns out that the receptor, the way that the coronavirus gets into a tissue or cell, in the lung, for example, is called ACE2. And this receptor is also present on the cells of the pancreas that make insulin. So the virus can actually infect the pancreas. And current thinking, I can't say it's proven by science, but the best scientific thinking is that is then predisposing the individual to the autoimmune inflammatory attack that in the end can lead to type 1 diabetes, as you suggested.
Dr. Lazar, you've been talking about type 1 and type 2 diabetes, and I'm wondering if you could give us a thumbnail sketch of the difference between the two.
Thanks for asking that question, because it's so important for our patients with diabetes to realize that the reason we call them all diabetics is because diabetes is a disease, as I think everyone knows, of high levels of sugar or glucose in the bloodstream, and type 1 and type 2 diabetics have that. But the way they get to that high glucose is very different. The classical one that most people are aware of is a complete loss of insulin due to the body's own immune attack on its insulin-producing cells. That's the type 1 diabetes we were just talking about. And that's almost a complete lack or deficiency of insulin. Now, that is the one everyone is most aware of, but in terms of the prevalence, it's actually the minority of patients with diabetes that have type 1. The vast majority, maybe 90 or 95%, have type 2. In type 2 diabetes, one of the main problems is not the autoimmune attack on the pancreas that prevents the ability to make insulin, is actually the body's own inability to respond to its own insulin, which forces the pancreas to make more insulin. And eventually the pancreas poops out and can't keep up with the demand. It's called insulin resistance when you can't respond to the insulin. And so at a certain point, even with insulin still in the bloodstream, patients with type 2 diabetes begin to be unable to keep their blood sugar in the right range through their body's normal auto-servo mechanisms, which are what endocrinologists study. And then the blood sugar creeps up, and that is what is type 2 diabetes.
Now, you have written, I believe, that steroids, which, as we should all recognize, are an important treatment for people with severe COVID-19, can be a problem for people with diabetes. Can you explain that, please?
Yes. Let me first clarify for the audience that when we talk about steroids here, we're talking about a class of steroids that are called glucocorticoids, like cortisone, the body's own glucocorticoid. We're not talking about other steroids like the androgenic steroids that athletes might take to get an edge, even though they're often referred to as steroids, which they are structurally. But these glucocorticoids are a really important hormone made by our own adrenals, and normally our body regulates things normally. Very few people, but some actually have a problem with their adrenals. But over the years, it's been realized that when you give these glucocorticoids in very high doses, and these are now drugs, so they have names that people are familiar with, like prednisone or dexamethasone, also cortisone. That's a pharmacological use of the hormone. And when that happens, it has anti-inflammatory effects. So that's why they're used for people with back pain or for rheumatoid arthritis or lupus and so on. But then there are side effects because of other effects of these hormones in high doses. And those side effects include effects on the liver and on fat tissue that causes blood sugar to go up. And so people who are predisposed to diabetes can now get diabetes, usually type 2, and people with type 2 diabetes, it gets worse.
And Dr. Lazar, the use of corticosteroids has turned out to be beneficial for people with COVID-19 when they're having that cytokine storm.
Exactly. And it's pretty much the same reason that we give prednisone or dexamethasone. And in the case of COVID-19, it's dexamethasone, a very powerful glucocorticoid steroid. It's the same reason it's given for inflammatory conditions like rheumatoid arthritis and lupus and so on, except here the inflammatory condition is that cytokine storm caused by the virus. And so it's been shown, in fact, it's other than the monoclonal antibodies that are hard to get and that are approved for emergency use by the FDA, it's really the only other therapy that's been proven to reduce the severity and mortality of severe COVID. But of course, the catch-22 is that this class of drugs can make diabetes worse, and it's diabetics who are more predisposed to severe COVID in the first place.
You're listening to Dr. Mitchell Lazar. He's the Willard and Rhoda Ware Professor in Diabetes and Metabolic Diseases, and he's the director of the Institute for Diabetes, Obesity, and Metabolism at the University of Pennsylvania.
After the break, learn about the causes of the obesity epidemic.
Why is obesity so closely linked to diabetes?
What food choices does Dr. Lazar recommend to his patients?
You'll also learn what Dr. Lazar prefers to eat himself.
Should diets differ between type 1 and type 2 diabetes?
Dr. Lazar tells how continuous blood glucose monitoring can help people manage their blood sugar.
What advice does he have for parents of children with diabetes?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. Kaya Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's Kaya Biotics.com. Use the discount code PEOPLE for $10 off your first purchase.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon.
The People's Pharmacy is brought to you in part by Kaya Biotics, organic probiotic products made in Germany. skayabiotics.com.
And by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Our topic today is diabetes, both type 1 and type 2. Why is obesity such a problem for type 2 diabetes? What are the best food choices for people with this metabolic condition, and do they differ? What is continuous blood sugar monitoring, and why is it so helpful?
We're talking with Dr. Mitchell Lazar. He is the Willard and Rhoda Ware Professor in Diabetes and Metabolic Diseases, and he's the director of the Institute for Diabetes, Obesity, and Metabolism at the University of Pennsylvania.
Dr. Lazar, there's an obesity epidemic in the U.S., and I might add, around the world, and for years we have been told that people get fat because they eat too much and they move too little. It's called the energy balance model of obesity. But there was a recent essay in the American Journal of Clinical Nutrition written by some pretty distinguished nutrition researchers, and they're proposing a different model that might work better. They call it the carbohydrate insulin model. Can you explain what they're talking about and what the difference between these two ways of understanding obesity is?
Sure, I'll give it a try. When the body gains weight, in obesity, we're talking about people who weigh more than average for the population to a degree where it's so much that we consider them obese rather than just overweight. And most of that weight is stored in fat tissue, which is sometimes called adipose tissue as the technical term. And when we think about where the mass comes from to make the fat, it comes from calories. And everyone knows about calories, and we count calories, but calories are a form of energy, and fat tissue is a way that our body stores the energy. And everyone agrees that there has to be an energy balance in the sense that the calories that you store must come from calories that you eat. In trying to expand upon this, nutritionists and scientists have come up with the idea of the energy balance equation, which basically says the amount that you eat minus the amount that you burn up, for example, by exercising, equals the amount that you store. So the idea would be that if you eat more than you burn up, you're going to store more, and over time that you're going to be in positive energy balance, which sounds like a good thing, but actually, if you're thinking about obesity, it's not a good thing because it leads to obesity. And everyone basically agrees that that's true. That's basically one of the laws of physics. But the question becomes, why don't we stop eating when we get to a certain level of adipose, of fat? And the sort of dogma is that it's a matter of the person's either willpower or sometimes some genetic reasons that are normally there to program us to stop eating when we have eaten enough. And that's the classic model. And I have to say, I'm still a believer in the classic model based on the evidence. But it's been suggested by the scientists that you mentioned that we've known about this classic model for a long time, and all sorts of diets have been tried. It's a multi-billion-dollar industry, and it just doesn't work. The recidivism, people can lose weight, but the recidivism, meaning how often they actually keep the weight off for a long time, the recidivism is high, which means that they don't keep the weight off very often. Many of the listeners, I'm sure, have their own personal experience with this. And what the scientists that you mentioned have been suggesting is maybe we need to look at this in reverse. And that even though it's an equation, calories in, calories out, so to speak, that it's not just calories in that are driving how much we store, but that it's the type of calories that we eat and the way we store them that might affect whether or not we're able to turn off our appetite or whether we feel hungry. And it's a great thing that people are questioning the dogma because we have an obesity pandemic that's leading to a type 2 diabetes pandemic, and we need new ideas. I would categorize these as really interesting, but needing to be proven.
Dr. Lazar, perhaps you can tell us why obesity is such a problem for the diabetes pandemic?
Yes, Terry, it's really an association. We know that obesity causes type 2 diabetes. And we know that because not just we see the association in people, but in scientific studies in animal models like mice where you can make them obese, we see type 2 diabetes or blood sugar going up. So we know there's this association. We know obesity causes type 2 diabetes. The exact mechanism by which it causes type 2 diabetes is actually also a scientific controversy. In a sense, there are more possible things out there that could cause it than are likely to be the case. And so the state of modern metabolic sciences for this point is trying to understand how obesity does this. One way is that the fat cells might make hormones. We know that fat cells can make hormones. Some of them might promote diabetes. We know that when you store fat in tissues other than fat cells, which happens if you get so obese that your body kind of spills over and stores it in the liver and muscle, that can lead to insulin resistance and diabetes. And there are a couple of other theories out there, and they may all be true for certain people. They may all be true a little bit, but that's kind of the state of the science right now.
There was a time when diabetes experts such as yourself or nutrition experts who worked with people with diabetes would tell people to calculate their calories very carefully and you know substitute this for that, and it was a challenge for a lot of folks, and I think a lot of the dietary recommendations were actually to cut down on fat and increase your carbohydrate intake. So in other words, people would say, okay, I'll buy the low-fat, no-fat fruit yogurt, which had a fair amount of sugar in it. And now we're beginning to question that wisdom. Could you give us some insights on actual food choices and what you're recommending to your patients?
Yeah, this is where we really get to the no pun intended, the meat of the controversy here. You know, the recommendation for low fat, I think, was based on a couple of things, but one was the relationship between dietary fat and cholesterol levels. And we know cholesterol levels predispose not to diabetes per se, but to heart disease, which is actually what is the cause of death for diabetics when diabetics, die related to their disease and just in our society. And there's no doubt that cholesterol is, our cholesterol levels are a predictor of heart attack and so forth. But what's changed in our thinking is that the cholesterol in the food is directly related to the cholesterol in our bodies. And it turns out that's largely not the case. For some people it's true, but for most people it's their own bodies making cholesterol in excess due to genetic factors. And that's why many patients are taking statins to lower cholesterol, and that's having a proven effect on reducing cardiovascular disease, heart attacks, strokes, and so on. But the dietary part of that is much less clear. And now, of course, we have statins that can take care of it without the diet. So that has caused people to re-examine whether low fat was really a good recommendation in the first place, especially because if it's not low fat, if it's low fat, it has to be high carb for the same number of calories. And this is where calorie counting isn't such a terrible thing. It is really difficult to do. And I know from personal experience how difficult it can be and how surprising it is sometimes how many calories one is eating. But the real issue is, are those calories going to be from fat or from carbs in addition to how many there are? So how many there are, in my opinion, still matters quite a bit, and people should be trying to reduce the total amount of calories that they take in, even though it's so difficult. The question has been, well, if maybe it's not the fat that was bad for you, and maybe actually, and I probably should point out that in a diet, if you think about what the components are, you can break it down into fat, carbohydrate, and protein. And it's very hard to eat a very high protein diet or a very low protein diet. So therefore, most diets have roughly the same amount of protein, and the difference is whether the rest of the calories are coming from fat or carbs.
Now, Dr. Lazar, if I were, which I hope I never will be, if I were diagnosed with diabetes and I came to your clinic and I saw you, what recommendation would you give to me in terms of what I should be eating?
Well, that is a great question. And again, here I think it's driven a lot by the individual. So I would absolutely say try to lower your body weight if your diabetes was associated with overweight. And I would say one thing to do is to try to reduce the amount of calories. Don't go for second servings. Overall, don't be careful what you eat. And then you'll say to me, as you should, and as you're basically asking in this question, well, should I eat the low fat or the low carb diet? And here, because my view of the evidence is that there's evidence that both can work. The Pritikin diet, which many people use, is a low fat diet, and it works very well. But low carb diets, the extreme of which are sort of the ketogenic or Atkins diet, also work pretty well. So what I usually do, and I also apply this to myself, I would add, is to try one or the other and see if it works. If it works, that's the answer to the question. If it doesn't work, try the other. So if you've tried a low-fat diet and you've eaten those yogurts that you didn't realize were full of sugar, switch and now try to be less careful about the fat in your diet, be more careful about the carbs in your diet, and monitor yourself, see what happens. And I actually believe, both from my personal experience and scientific knowledge, that although we don't have all the variables and all the answers yet, that this is going to turn out to be an individual difference, that there'll be genetic differences between people, maybe small differences, but that determine ultimately whether for me, a low carb diet is going to work better than low fat, but for you, a low fat diet is going to work better than low carb. I don't have a crystal ball, but I think within 10 to 15 years, not tomorrow, with the understanding of the human genome and some of the complexity, we'll start to be able to predict which people respond to which diet. And I think that will reduce some of the confusion, because we look around and we see one person saying the low carb diet worked for me and another person saying the low fat diet worked for me, and way too many people saying none of these diets are working for me.
And in the meantime, trial and error is the best way to figure out which diet will work best for a given individual. But Dr. Lazar, you've piqued our curiosity. Which one does work best for you?
For me, I think a low carb diet works best. And there are a couple of reasons why. One, which actually fits into the carbohydrate insulin model, and I think there's some credence in that, is that carbohydrates cause your body to make insulin. We talked about insulin as a good thing in terms of diabetes, but insulin also drives the production of fat in your body. And we know that different foods have different so-called glycemic indexes. Different foods will increase the blood sugar more than others. So I think that's part of it. And that's what the carbohydrate insulin model people are suggesting. And I think there is definitely something to that. But for me personally, I think it's because I grew up in a middle-class family in which I was basically told to eat everything on my plate and everything that I buy, because I don't want to waste money and I don't want to, I want to be economical and so forth. So I eat everything on my plate. And when I'm really strictly following a low-carb diet and I don't eat the pasta and I don't eat the potatoes and I don't eat the bread, and by the way, bread is what gets me off the low-carb diet, I'm sad to say, because I love it so much. But it's a way of excluding foods that are otherwise available to me. I'm kind of a good rule follower. And so if the rule is don't eat those, I can do that. But otherwise, I eat them and I probably eat too much of them. So that's, again, I want to emphasize that's how I feel about myself and why it works for me as the answer to your question.
Dr. Lazar, any difference between people with type 1 and type 2 diabetes as far as your recommendations about diet?
Yeah, I would say that patients with type 1 are less likely to handle a massive, incoming of carbs. And so I think low carb makes even more sense for them. But otherwise, the same logic. And I think there are some people that are suggesting that, although insurance companies will not pay for this, that now that we have these really fantastic technologies to measure our blood sugar, and diabetics have that actually, so they can do this, but people who don't have diabetes but are worrying about this don't have this option. But for diabetic, many of them have these so-called continuous glucose monitors, and they can test on themselves. They can test, meal 1, meal 2, see what happens to their sugar, and again, learn about themselves. And I really think that as much as any given food is more likely to increase blood sugar or increase insulin in general, I also know that that'll be different from person to person. And with the glucose monitors, people can try to figure that out for themselves.
And that is what the research has shown, that even as we're talking about glycemic index, there is no standard glycemic index. Apparently, it varies from one person to another, and perhaps our gut microbes have an impact on it. We don't know. But definitely, if you have the opportunity to find out exactly which foods make your blood sugar spike, that would be a very good thing to know.
Totally agree.
Dr. Lazar, do you have any advice for parents of children with diabetes?
Well, there's evidence that diabetes is inherited, and that's a couple of ways of looking at it. One is if you look across siblings, and if you look at twins, for example, identical twins with the same genes, if one has type 1 diabetes, the other has about a 50% chance of having type 1. It's not 99%, partly because of this variable of viral infection that we were talking about earlier, whatever the trigger is for the type 1 immunity. But type 2 has what's called a concordance rate, meaning if twin 1 has it, will twin 2 have it, a very high concordance rate, 90% or higher. So this really tells us it's a genetic disease. And of course, if you look at your parents, you have 50% of the DNA of each of them. And so you're more likely to inherit their predisposition to type 1 or type 2, and especially type 2. Can you stave it off by diet and exercise? There are now, of course, most of the studies on that are really in adults, but we can extrapolate to kids. We know that a good nutritional program, good coaching, also possibly some medications, but it'd be nice not to be on medication, especially for kids, of course, that you can reduce the risk of developing it, even if you're predisposed, by being careful. Again, it is, in the end, partly about calories, but it may be the types of food. And of course, if we're talking about kids, which I think is where you started, I'm sorry if I deviated a little bit there, they're likely to be eating what the family is eating at family meals. And so I think suggesting that they avoid processed foods and avoid foods that have very simple carbs and are just not that good for you, and eat what the family's eating, which hopefully includes salads, and if there's carbs, maybe complex carbs, and so on.
You're listening to Dr. Mitchell Lazar. He's the Willard and Rhoda Ware Professor in Diabetes and Metabolic Diseases, and he's the director of the Institute for Diabetes, Obesity, and Metabolism at the University of Pennsylvania.
After the break, we'll find out about something a little mysterious called prediabetes.
What are the most important risk factors?
Circadian rhythms influence blood sugar and metabolism. What are the practical implications?
Is there a connection between insomnia and metabolic problems?
Dr. Lazar also describes how people with diabetes should approach intermittent fasting.
You're listening to The People's Pharmacy with Joe and Terry Graydon. This podcast is brought to you by the Verrazana Health Club. This comprehensive home testing service enables you to track crucial health markers of gut health, inflammation, metabolism, hormones, thyroid function, and many other organ systems. Regular testing can help detect health imbalances before they lead to sickness. Online at Verrazana, verizana.com/health-club. Get 50% off the first month with the discount code PEOPLE50.
Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon.
The People's Pharmacy is brought to you in part by Verrazana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verizana.com. sana.com.
And by Kaya Biotics, organic probiotic products made in Germany, KAYA Biotics.com.
Also by Cocoa Via Memory Plus, a cocoa flavanol supplement backed by 4 clinical studies that show significant improvement in 3 different aspects of memory. More information at cocovia.com.
Do you have prediabetes? How would you know? What are the risk factors for this metabolic condition?
How does the time of day affect your blood sugar response? If you have trouble sleeping, how does that impact your blood glucose control?
Our guest today is Dr. Mitchell Lazar. He is the Willard and Rhoda Ware Professor in Diabetes and Metabolic Diseases, and he's the director of the Institute for Diabetes, Obesity, and Metabolism at the University of Pennsylvania.
Dr. Lazar, we've been talking about type 1 diabetes, which is relatively uncommon, compared to type 2 diabetes, which, as you've described, is a worldwide pandemic. But now I'd like to ask you a bit about prediabetes. There are some people who say, oh, that's overdiagnosing. But it seems to me there are an awful lot of overweight people around the world, and in particular in America, and a lot of them are on the verge of developing type 2 diabetes. So could you explain what prediabetes is?
Sure. Prediabetes, sometimes it's called impaired glucose tolerance. It's a term used for people who, by some criteria, usually related to blood sugar, are not diabetic based on the current criteria, but are likely to be at risk because they're still higher than most of the population. And I think some of the confusion about this and some of the real difficulty in talking about it is that when we think about the diagnosis of diabetes, everyone knows it's high sugar in your blood. But how do we know you have diabetes? Well, right now, we say you have diabetes if your blood sugar is above a certain number. And that number, when fasting, is 126 milligrams per deciliter. But the blood sugar is what's called a continuous variable. And so if you're 125 milligrams per deciliter, you don't have diabetes. But it stands to reason, maybe it seems obvious, that if your blood sugar is not super low, in which case you have hypoglycemia, that 125 is a lot closer to 126, and of course 120 closer than 115, and so on. So to the extent that the blood sugar is driving a risk of the complications of diabetes, because at the end of the day, what we really care about is not whether we call you a diabetic, but whether or not you're at risk for the problems that diabetics get into, which include heart disease, stroke, blindness, kidney disease, neural damage, and so on. So I think that's what's led to the thinking that, well, if we're treating people with 126, why don't we treat people with 125? And the other point is that if you're 125, you're much more likely to go over 126 and become in the diabetic diagnosis group than if you're starting at 90. And so, although we artificially create a line and say if you're above this line, you have diabetes. If you're below, you don't have diabetes. But if you're above something even lower, you have prediabetes. In between, that's really artificial. And it is true that obesity is the corollary or the predictor of both being pre-diabetic and, as we said, for type 2 diabetes. So I think that's why we get into this question. And it's also been shown that people with prediabetes are more likely to get diabetes. Again, that's because their number is closer. That's how I look at it. But also they might get diabetes but actually go back down again without dramatically changing their lifestyle, because there's a bit of variation around that. Now, the higher it is, so we were just talking about 125 versus 126, but if you're 250 or you're 400, that's really bad. Then there's no doubt that you have diabetes. Then you're super likely to get both acute problems from the really high sugar, but also the chronic problems that are driving the lower lifespans and health spans of people with diabetes. So to me, when we talk about the pre-diabetic versus diabetic, that's the problem, is that we're talking about a definition, and we should be thinking about the risk factors. And some of the risk factors are not just the blood sugar, it's other aspects of obesity, which include predisposition to cardiovascular disease and so on.
What would those risk factors be?
In terms of being, well, obesity is by far the major risk factor of type 2 diabetes. Interestingly, when we talk about obesity, obviously food intake, and whether it's quantity or quality of the food is what we've just been talking about. But there are other factors which include genetics and also other environmental factors, such as even circadian rhythms and whether a person is working at night. People on the night shift have a 400 or 500% increased risk of obesity, and then, of course, as we've just said, type 2 diabetes, cardiovascular disease. So there are other risk factors, although the main one is related to diet.
Well, Dr. Lazard, thank you for mentioning circadian rhythms. That's where your research has really focused, on circadian rhythms and metabolism. I'm wondering, we don't want to get into all the most detailed scientific explanations, but perhaps you could give us the practical implications for people with diabetes.
Well, thank you for asking that question. And I think about that all the time based on some of the basic understanding we have and just the experiential understanding that, as I mentioned, people working the night shift have an increased risk of, broadly speaking, metabolic disease, but especially obesity and type 2 diabetes. So one thing to prescribe would be don't work on the night shift, but that's not so easy for people. I think from a scientific point of view, if someone has to work on the night shift, the recognition is that our bodies have their own internal clocks that have pretty much evolved to match the 24-hour day, which is really a function of the fact that our Earth turns on its axis once every 24 hours. And as far as you know, that's happened for a really, really, really long time. And in evolutionary terms, things that we observe today that are likely selected for. So there was probably an advantage in evolution to anticipate that when you wake up, you're going to eat. And when you're asleep, you're not eating. So our bodies have pre-programmed metabolic rhythms, both in our genes, in different parts of our body, as well as in our bloodstream, and the glucose and triglycerides and so forth. These all have circadian rhythms. And when a person now, I'll say behaves, but let's say works on the night shift, and the way they act is in opposition to what we were programmed for, it creates kind of a dissonance. And it seems that the way the body deals with that is by having disorders of metabolism. So what I would recommend is that people try as much as possible to eat at times of day when they would normally be eating, although obviously that's not possible for someone working on the night shift and sleeping during the day, but try to bring it as close as possible to what we were programmed for with regard to light-dark cycles and, activity cycles.
Now, does this also have anything to do with insomnia? As I understand it, people with sleep problems sometimes also have metabolic problems. Have you seen a connection?
They definitely do. And it's very complicated, the relationship between sleep and metabolic problems. The aspect that I was just talking about, which has to do with kind of a mismatch of, now if they're insomniacs, so now they're going to be eating when they should be sleeping, that could be a big part of it. But it's also true that some people with sleep disorders have metabolic problems. For example, people who are obese to begin with can develop sleep apnea, which is a sleep disorder that prevents their sleeping normally. And it's highly related to body weight and body habitus. At the same time, it's been shown that if you have sleep apnea, which means you're waking up to breathe at different times of day, you're not getting of night, not getting full sleep, that actually is another predisposing factor. You asked earlier about the risk factors for type 2, and I didn't mention this, but I should have. sleep apnea and not getting enough oxygen to the body is another risk factor for developing type 2 diabetes. So again, we have a vicious cycle because the type 2 diabetes and the weight gain associated with more apnea, the apnea more type 2 diabetes, and so forth. And it's a very difficult cycle to break out of. Things like CPAP, positive pressure, for this very common problem, especially in obese people, but not only obese people, seems to be the best treatment at the moment, but it's not a panacea, and we need definitely more work and more research on this.
Dr. Lazar, you mentioned that from an evolutionary perspective, not eating while we're sleeping, that is to say at night, is probably a good thing. That's sort of programmed into our genes. But I'm wondering about intermittent fasting. There is I won't call it a fad, but a growing movement to suggest that people should have at least 12 hours when they're not eating. And so a number of our guests have been advocating, if you're going to have breakfast and you're going to have lunch, skip dinner. Any thoughts about intermittent fasting for people with diabetes?
I think that you described it very well, the intermittent fasting paradigm. And I would add that it's, in a sense, a way of, and many of the people who advocate for it bring up the issue of circadian rhythms and the kind of thing I was just talking about. And they're trying to really, I won't say shoehorn, but to really make it the case that you're eating when you're supposed to be eating in this evolutionary program way. That is basically the underlying principle. And it does seem to work for some people. There are some studies that are very positive. There are some studies that are less positive. And it's another example, and I'm sorry if it seems like a cop-out, but I really believe this, that because we don't have the full scientific knowledge, but it makes a lot of sense, that it's worth trying. So I think it's worth people trying, especially diabetics, but really anyone who's trying to maintain their body weight. And if it works for them and it's not intolerable, there's no reason not to do it.
Now, there is a caveat, of course, and it has to do with, I would say, primarily type 1 diabetes. And that's if people have low blood sugar. We always talk about the high blood sugar, problem, 200, 300, 400. Yeah, that's pretty serious. But when a person with type 1 diabetes gets down in the 40s or 50s, that's also a problem. And intermittent fasting for them might pose a problem.
That's really a great point, Joe, and I completely agree with that. And of course, the minority of people we'd be prescribing or suggesting that to are type 1, so I didn't emphasize that, but I completely agree with you. We do hope for type 1 diabetics who are taking insulin pretty much by definition that they need to be taking insulin and having some insulin coverage at all times. We know that no matter what dietary regimen they're on, they're going to have some predisposition and some bouts of hypoglycemia. It's hoped that with the glucose monitoring that we talked about, but also the body's own signals that tell a person, hey, your blood sugar is low, you better eat. And that's usually not only hunger, but a feeling of sweating and agitation. And diabetics know what that feeling is, except with advanced diabetes, when over time, because of neural damage, they develop or can develop what's called hypoglycemia unawareness. It's the people with hypoglycemia unawareness that I really worry about in general, and certainly if you're telling them not to eat, when in fact if they have a low blood sugar, they should be taking in some sugar.
Dr. Lazar, we keep hearing about a connection between dementia, and in particular Alzheimer's disease, and blood sugar levels. That is to say that people with type 2 diabetes, and maybe even type 1 diabetes for that matter, who have difficulty controlling their blood glucose levels may be more susceptible to Alzheimer's disease. What's your thought on that?
Yes, thanks, Joe, for that question. It's really a good one. And these relationships are there. Exactly the causality is not clear to me. I've thought about this. I tend to think about it more broadly from a metabolic point of view. Yes, blood sugar could be part of it, but also lipid abnormalities. And in fact, one of the strongest risk genes for Alzheimer's disease is in a protein that's a lipoprotein, a protein that's involved with lipid transport. So I think it's the metabolic connection, and whether or not that's indirect through hormones that get produced in the body and then go to the brain, or whether the brain itself is dealing with inappropriate levels of metabolites like fat and sugar, I don't think we know right now.
If you were to look into your crystal ball and talk to some of the leading researchers who are working in the field of type 1 diabetes, what do you think future treatments might look like, either to prevent or, to better yet, control type 1 diabetes after the diagnosis, but before all of those beta cells, those islet cells in the pancreas, are destroyed? In other words, what about immunomodulation or some other approach?
Great question, and I'm really glad you're asking me that question now, because I think there's some real hope there. I'll start with immunomodulation because you mentioned that. And, we can't predict who's going to get type 1 diabetes, although it does run in families, and there are some signs like people who have antibodies to insulin in their bloodstream are more likely to develop diabetes. In the past, the barrier to using immunomodulation has been just too great because, number one, you're treating largely children, and we have a much higher threshold for what we give to children as medication has become obvious in the discussion of vaccination, for example. And also, drugs that affect the immune system can cause increased infections. They can predispose to certain cancers, lymphoma. And so nothing along those lines has really worked so far, and there's been a very appropriately cautious approach. But at the same time, there's an immunorevolution in the way we think about how to treat cancers with immunotherapy in a way that was never thought of before. And there are some new, exciting thoughts out there about how to very specifically eliminate the cells in the body, the immune cells that might be causing type 1 diabetes. So I think this prospect that's not here now is very exciting.
Dr. Lazar, I have been fascinated with a very old drug that was originally developed from the French lilac plant, a drug called metformin. It's been around for decades. It's cheap as dirt. It is probably the number one most prescribed drug for type 2 diabetes in the world. And now people are talking about using it as an anti-cancer drug for patients with prostate cancer or breast cancer. It's being discussed as an anti-aging drug. I mean, metformin is getting more attention these days than it did 25 years ago. What are your thoughts about this very old drug?
Yeah, it's a great question. And you're right. It really has great promise. As you say, it's inexpensive. That's important to know. And it also has effects that were initially noted in terms of lowering of blood sugar in type 2 diabetics, but may extend to cancer and other conditions, as you mentioned. Now, I do believe in the sort of the statement attributed to Hippocrates of above all, do no harm. So everything else being equal, I wouldn't either take or prescribe a drug if I didn't have to. In the case of metformin, the situation historically is a little bit clouded because of another version of a very similar molecule called fenformin was introduced in the United States several decades ago. And there were a couple of cases of what's called lactic acidosis, which is a life-threatening illness. And it's actually due in part to how the drug works, because both metformin and fenformin work in part by making the energy cells of our bodies, the mitochondria, a little bit less efficient, which turns out to be not such a bad thing when we're dealing with harmful levels of glucose and lipids and so on. But because of these rare but devastating cases of lactic acidosis, fenformin and then metformin were not approved in the United States for many years. FDA, we know, is super cautious. Metformin was approved in Europe, and that's when we discovered that, hey, this drug is actually working over there. And eventually, American physicians and regulators realized that the good was greater than the harm, especially for people with established type 2 diabetes. And now it's probably the most widely used drug for type 2 diabetes. But whether it should be given to those people with prediabetes that we discussed earlier, or just put in the water and given to everybody because of all those great things you mentioned, that is an area where I think caution is due. We just don't have the answer to that. Studies are being done. If there are other conditions, for example, metformin can help polycystic ovarian syndrome. So if someone had polycystic ovarian syndrome and prediabetes, which goes with PCO, that would be, to me, a very good reason to try metformin. But I wouldn't give it to everybody just yet.
Dr. Lazar, there are a bunch of new diabetes medicines on the market. They're pretty expensive. And there have been some concerns about pancreatitis, maybe even pancreatic cancer. Are you at all concerned, or do you think nothing to worry about?
I think you're referring largely to the drugs that are in the so-called incretin class, like GLP-1 analogs and so on. And my reading of literature on that is that it is really overblown. And the main reason to not take those drugs would be the cost of the drugs. If you could take metformin or something that is cheaper and effective. But if metformin is not working, adding on an incretin or a GLP type molecule, I think every drug we take has risks, but it's relatively safe. And also those drugs have the added advantage of improving weight loss by mechanisms that are just beginning to be understood. So yes, it's a concern. And I think if a person has a history of pancreatitis, that would be a reason not to take it. But otherwise, occasional monitoring for pancreatitis would be sufficient. I do have no qualms about prescribing that drug.
Dr. Lazar, statins, they are taken by tens of millions of Americans. And I know that most people who specialize in diabetes treatment, such as yourself, would recommend a statin to anyone who has been diagnosed. And yet there is the problem of statins actually making control of diabetes worse for some people, or actually inducing diabetes for others. Any recommendations on how our listeners on statins should behave in terms of tracking their blood sugar levels?
Another great question. And I would say there are sort of two issues. One is, do you give a statin to a diabetic? And if you're on a statin, how do you make sure you're not going to become a diabetic? And maybe those are related. I think the effect of the statins is a statistical effect. It's a small effect on blood sugar. And because blood sugar, as we talked about, was a continuous variable, some people are going to bump up from 120 to 127, and now they'll be called diabetic. So in my opinion, the magnitude of the effect with statins is really not that worrisome in relation to the magnitude of the benefit, which has been proven for cholesterol, LDL cholesterol lowering by statins, and the prevention of heart attacks and strokes, which are the main thing that diabetics die from. So again, caution would be important. People taking statins should more frequently than otherwise monitor their blood sugars. People with diabetes should be careful about this. If they notice that their insulin requirements or their other aspects of their diabetes are getting much worse, they should talk to their physician and probably stop the statin. But in general, I think it's okay.
Dr. Lazar, our time with you is almost up. So I'm wondering if you have any advice for all of us to what should we be doing if we can to prevent or avoid diabetes?
Well, for sure, we should be keeping our weight in the normal range, keeping it down. We've already discussed how challenging that can be and how it may not be again, pardon the pun, but a one-size-fits-all model for that. But to be vigilant about it, not just there is a tendency, I think, for people to say, and I have this myself, well, it's only 5 pounds and I'll go on a diet next week, or I'll do something about it next week. But it's really insidious. This is a problem that's affecting millions of people. It's a pandemic by definition, not an acute one like the COVID pandemic. But it's one that, especially with advances in cancer treatments, is really going to affect our lifespan and health span and that of the next generation to come. And it's really, we're talking about millions of people. So I think my best advice is take it seriously. Don't just say, I'll wait till tomorrow. No one would say, I have a cancer diagnosis, I'll wait till tomorrow. But they do that with blood sugars that are going up or weight gain and so on. And that's where I think vigilance would really be valuable.
Dr. Mitchell Lazar, thank you very much for talking with us on the People's Pharmacy today.
Thank you, Terry and Joe. It's been a pleasure, and hope we can do it again.
You've been listening to Dr. Mitchell Lazar. He's the Willard and Rhoda Ware Professor in Diabetes and Metabolic Diseases, and he's the director of the Institute for Diabetes, Obesity, and Metabolism at the University of Pennsylvania.
Are you at risk for prediabetes? When was the last time you had your blood sugar measured? Do you know what your blood glucose level was or your HbA1c number?
Have you taken action to get your risk factors under control? If you're a shift worker, you may have a harder time managing your blood sugar levels. If you have sleep apnea or difficulty getting a good night's sleep, you might also find it harder to control your metabolic response. We hope today's interview has given you the foundation to make some changes and get the help you need from your healthcare providers.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. The great B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
The People's Pharmacy is brought to you in part by Verisana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocoVia, maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
Also by Kaya Biotics, probiotic products made in Germany from certified organic ingredients, KAYA Biotics.com.
Today's show is number 1275. You'll find it online at peoplespharmacy.com. You can subscribe to our podcast through your favorite podcast provider. We post the show on our website on Monday morning. This week's podcast contains additional information that wouldn't quite fit in the broadcast today, including a possible connection between blood sugar levels and dementia, and some future approaches to control the immune system to improve or even reverse type 1 diabetes.
If you'd like to make a comment about this show, look for the post on our website, peoplespharmacy.com. It's show 1275.
At the website, you can sign up for our free online newsletter and get the latest news about COVID-19 and other important health stories. By subscribing to our newsletter, you'll also have regular access to our weekly podcast and find out ahead of time which topics we'll be covering.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week.